Okay, all right. So hello, dears. Welcome now to the second part on our lecture welcome now to the second part of our lecture on rheumatoid arthritis. Okay, and for this part, what we're going to discuss now is the immunologic findings of the disease. All right. Okay, so we'll start first with the lesions in the rheumatoid joints. If you examine it, there's an increase in cells lining the synovium and infiltration of cells, mostly CD4 plus T cells or your helper cells. The CD8, B cells and plasma cells also are scattered throughout. So as you can see, there are a lot of immune cells, that are in the joints mismo. Okay, so they're crowding in the joints. Okay, aside from that, because of these immune cells, the phagocytes, they're attracted, okay, forming an organized mass of cells called a Panus. Okay, Panus. Okay. If naguba na yung food or di na siya makaon, na Panus na siya. But anyway, that's Panus, which grows in the joint space and invades the cartilage. So the Panus is a mass of phagocytes, of your immune cells that are found in the joints. And then they increase in size, okay? Because again, of the increase in the number of cells. So of course, mga matay sila, so mag-combine, and then they accumulate, all right, and that forms your Panus. Okay, all right. And there is an abundance of pro-inflammatory cytokines. Ayan, so very popular, dagan kay mga cytokines. You have IL-1, 6, 8, 15, 18, and TNF or tumor necrosis factor alpha. And tumor necrosis factor alpha plays a key role in the inflammatory process by inducing the continual secretion of IL-1, IL-6, and IL-8. And it also facilitates the transport of white blood cells to the affected areas. Now, recall, di ba? Nakita nyo na to. Silang 1, 6, at saka sa TNF-alpha. Asaman? Sa ato ang CRP na lecture. Because again, di ba, these three cytokines usually are the major ones. Major cytokines which induce the secretion of your acute phase reactants from the liver. Di ba? So hence, since naman sila diri, increase man ilang number, 1, 6, o TNF-alpha, sila pa yung tulo, yes, the besties, sila pa yung tulo, 3 and 1. So therefore, because of increased cytokine production, there is also an increase in your APRs, or your acute phase reactants, okay? Hence, which leads now to inflammation. So naadyo inflammation na hitabo, alright? So therefore, if a patient has RA, or rheumatoid arthritis, pwede po siya mo-positive or increase po yung amounts of your APRs. So, mo-positive po siya for CRP. Okay? Alright, because again, this is an inflammation. There is chronic, continuous ang inflammation na hitabo sa body, sa imong joints. Okay? Alright. Now, because of that, collagenase and other tissue-degrading enzymes, they are released now from synoviocytes or cells in your synovium, sa joint cavity, and chondrocytes or your cells in the cartilage that line the joint cavity, resulting in the destruction of connective tissue, cartilage, and bone. So, it's like a cascade na gyud, mura siya mga consequences na sa nahitabo. Because of increased cytokines, increased APRs, it then triggers the release of these enzymes from the cells in your synoviocytes, and sa cartilage, which are your chondrocytes. Okay? Because again, of the increase in cytokines and all that. So, because these enzymes are released, then of course, it can now destroy the connective tissue surrounding the cartilage and the bone. So, which worsens the situation, okay? And also, an autoantibody, actually, two autoantibodies can be found. You have first the rheumatoid factor, which is what we'll focus in the later part of the slides or in the lecture, because again, muna siya to i-perform sa lab. We have a test kit for that. Autoantibody called rheumatoid factor can be detected. Now, this autoantibody, unsay ang composition, it's an IgM that targets the Fc portion of the IgG. Ayan. So, lumalabas sa boards. What can you describe, or what is the description of your RA, or RF? It's an IgM that attacks the Fc portion of your IgG. Okay, please take note. It's an IgM that attacks the Fc portion of your IgG. But for RF, man good guys, it's not only seen in patients with RA, okay? Because it can also be seen in 5% of healthy individuals and in 10 to 20% of those over the age of 65. So it's not that specific for RA, okay? But it's seen in patients with RA, but it's not only seen in patients with RA. Kaya hindi siya specific. Okay? Alright. Rheumatoid factor, again, on same composition or on same description, it's an IgM against the Fc portion of an IgG. Alright? So, visualize lang. So, IgM, gina-target niya ang IgG. Okay? So, it's an autoantibody. So, meaning, it's an antibody against another antibody. Or, yeah. Ana. So, actually, the pathogenesis or the purpose of the autoantibody, example RF, is not known. Alright? But, according to Stevens, one of the postulates or one of the theories daw na ilahang hatag sa scientists or other researchers is that the autoantibody triggers the increased antigen presentation of your APCs, of your cells, to T cells, which furthers the inflammation, okay, which furthers the immune response, okay? So, the autoantibody, again, it amplifies, it increases macrophage activity and also enhances antigen presentation to your antigen, of your antigen presenting cells to T cells, okay, which then leads to further worsening or increasing your immune response, okay? All right. Okay, now we have another pathogenesis niya is the formation of immune complexes, di ba? So since your, di ba, destroy naman ito yung mga bone composition and all. So because of that, no, the autoantibodies also form in the antigen presentation and all that. So they then form an immune complex or immune complexes, which then are deposited in the joints, which trigger a type 3 hypersensitivity reaction. So again, hypersensitivity reactions, guys, ipapaubay ako sa lecture, alright? Because dito mahuman na Japan if ato ng i-lecture diri. Alright? But hypersensitivity reactions are reactions of your immune system na I'd like to think na it's OA ra gyud ang immune system. So a very good example is your allergies. Ayan, so mga allergic rhinitis dyan, yes, me. So mga over ang immune system. So hypersensitivity meaning your immune system reacts on an antigen or on a foreign material that is not supposed to be a pathogen, parang ganun. So under normal people na wala hypersensitivity reactions, like if example dust, mabutang nila, no, their immune system will not react. But for patients with or people na naay hypersensitivity reactions, bisag normal lang, okay, na normal lang na dili gyud maka-cause og disease, mo react japon sila og reaction na same sa pathogen na maka-cause of disease. I'm not sure if nakagets mo. But that's how I interpret it, okay? That's for hypersensitivity, okay? And we have 4 types. You have, of course, 1, 2, 3, and 4. Allergies, mga allergic reactions, anaphylactic, no? Anaphylaxis, they're under type 1, okay? That's anaphylactic reactions. Type 2 usually are your type 2 kay antibody mediated, so na ay antibody na involved. Your type 3 is complex mediated, yes, here. And your type 4 is T cell mediated, so nanay involvement of T cell. And this is known as your delayed hypersensitivity, meaning it occurs after days pag yun, okay? Usually your hypersensitivity reactions, especially for allergies, they result or they effect immediately, pas-pas yun siya. Okay? Alright, ayan. So type 1 is anaphylactic, so mga allergies, ayan. Okay? Antibody mediated, okay, ang type 2. And type 3, immune complexes na. So nanay combination of soluble antigens and antibodies. Alright, na na-trigger ang complement system. Actually, ang end result is complement activation pa rin. Okay, because of immune complexes. Alright, okay. So di ba si sneezing girl, si allergies girl, yes. So, my gosh, bees, type 1 hypersensitivity reactions. Yes, okay. Alright, anyway, alright, so C1, it binds with the complexes, okay, because again, that were formed, no? From the degradation of your bones and all that, and the different immune cells that were found in your joints. Okay, joints. Pwede naman, joints, yes, okay. All right, and of course, generate C3A, C5A, which are again chemotactic factors, meaning they attract phagocytes, more phagocytes to the area. And the continual presence of macrophages leads to chronic inflammation, and which then results to damages in the synovium. All right. And also, there can be other autoantibodies that can be found. All right. Again, as mentioned, it's not only RF. Okay. Napay next autoantibodies, which is the next slide. Okay. All right. Ayan. And those are what we call these are the autoantibodies: anti-keratin, anti-perinuclear, anti-filagrine, and anti-SA. And these antibodies are directed against what we call citrullinated proteins, all right, that are generated, okay, by the modification of arginine by the enzyme peptidyl arginine deaminase. And this group of antibodies are known as your cyclic citrullinated peptides, or hence the antibodies are called anti-CCP, Anti-Cultural Center of the Philippines. Charot. Okay, all right. Ayan. So, sige. So, your enzyme peptidyl arginine deaminase, guys, is found in your macrophages, in your phagocytes. Now, di ba nasa sa synovium? All right? So, what happens is, okay, so if mamatay sila, your macrophages and monocytes, they then release this enzyme, peptidyl arginine deaminase. Now, this enzyme, all right, okay, it then modifies the proteins found in the synovium, all right, which then results to what we call the citrullinated proteins. Okay, all right. So the peptidyl arginine deaminase, iyahang i-modify ang keratin, anti-perinuclear, anti-filagrine, and other proteins, vimentin, found in your system. All right. Now what happens is, because of that, so na-modify na, if too much expression of that, of these antigens, it will now become antigens. Overexpression of those antigens, especially in patients with the HLA, DRB1, katong na-mention ako ganina, alright, DRB1 alleles, okay? If patients have those, alright, so diba, they are prone to RA. Alright, now in patients with HLA, DRB1, overexpression of the modified na, diba, mga citrullinated proteins, as mentioned, citrullinated proteins na sila, they then create autoantibodies against it, or antibodies. So, we have now anti-keratin, anti-perinuclear, anti-filagrine, and anti-SA, and other autoantibodies. And this family of antibodies, they are detected by using cyclic citrullinated peptides. Okay, because again, these are antibodies that are directed against citrullinated peptides or proteins, diba? So, we detect them using these cyclic citrullinated peptides in the laboratory. That is why these family of antibodies are known as your anti-CCP. And anti-CCP is now the lead marker for RA because it's much more specific than your RF. Diba, recall, ang RF, it can also be seen in healthy individuals. In other diseases po na mo produce og RF, so it's not specific for RA. Hence, ang anti-CCP now ang lead marker. And aside from that, according to Stevens then, yes, wala na ako na memorize, no? Okay. 20 to 30% now of RF negative patients are positive with your anti-CCP. And the presence of anti-CCP also precedes, meaning makita na siya before pa lang na ay onset of symptoms sa RA. Ayan. So therefore, your anti-CCP can also is the marker, a good marker for early detection of RA. Tama ba? Yes. Okay, tama. Marker for early disease. And aside from that also, the presence of anti-CCP can also be used as a marker for... yes, okay, tama. Okay, so the presence of anti-CCP was also associated with a increased likelihood of worse prognosis. Yes, okay. Yeah, to develop, if present daw ang anti-CCP, it's also a marker or associated siya with increased likelihood of developing progressive disease of the RA, which leads to worse progressive RA that has a bad prognosis. All right, but that's why it's recommended now that we test for RF and anti-CCP together because the specificity now is 98 to 100%. That's according to Stevens of 4th edition. All right? So 98 to 100% ang specificity if you test both RF and anti-CCP. All right? But if you are to be asked what is the lead marker or what is the more specific, it's anti-CCP. Okay? Press the buzzer. All right. Ayan. Okay. All right. I hope na-get lang to siya kay medyo naglayan na po akong feeling, but yes, sige, I hope na-gets lang. All right. Now, for diagnosis of RA, it's made on the basis of the combination of first, of course, clinical manifestations. So, we look for the symptoms, we look for mga joint pains, the nodules, bone erosion ba, X-ray, Of course, second is radiographic findings because again, this disease involve muna your joints, your bones. All right, so you want to see if na by bone erosion, displacement, and all that. And lastly, laboratory findings. And under laboratory findings, we then detect RF, di ba? Latex agglutination or heme agglutination tests, enzyme immunoassays or nephelometry. And for anti-CCP, you have enzyme immunoassays and rapid immunoassays or mga kits. Okay? All right. Now, what we're going to focus lang is the RF. Okay? Because muna siya ang natay test kit and muna siya to i-perform sa laboratory. Okay? In our class. All right. Yeah. So based on the 1987 criteria established by the American College of Rheumatology, so these are the symptoms, okay, or the criteria that is used to diagnose ba or to confirm if the patient has RA. So number one is morning stiffness around the joints, at least lasting at least 1 hour. Okay, so stiffness sa joints. Not sure if but I think sa hands, okay, or those that are experiencing pain na joints, okay? All right, so nice stiffness pagka morning. Uy. All right, okay. Swelling of the soft tissue around greater than equal 3 joints. So example, kanina joint sa hands, no? So soft tissue, so kaning skin there if na hubag-hubag, no? Greater than equal to 3 joints. Okay? All right. Swelling of the proximal interphalangeal, metacarpophalangeal, or wrist joints. So interphalangeal, phalanges, your fingers, diba? So interphalangeal, tama ba? Proximal, yeah, proximal. And metacarpophalangeal, so kanina rin, or wrist. Metacarpophalangeal, metacarpals is your wrist, diba? Carpals di ang wrist. Yes! Anatomy laban na. Okay, diba? So metacarpophalangeal, so kaning diri sa middle, and then the wrist, the carpals. Okay, all right. Swelling. Symmetric arthritis, diba? Defining again, symmetric. Kung unsay na kung arthritis na itabo diri, dapat napod sa PICAS side. Subcutaneous nodules, para sa sa picture ganina, na yung murag nodules na makitaan. Positivity for RF, radiographic evidence of erosions in the joints of the hands, wrists, or both. And again, at least 4, at least. So minimum of 4. So 4 and above of the criteria. If na-meet na siya, then the diagnosis can be made. And it's lasting for or present for greater than equal to 6 weeks. Okay, now you may be wondering, sir, wala pa laging anti-CCP dere. It's because 1987 pa man siya. So I think wala pa na-discover ang anti-CCP dito. Okay, so it's quite recent ang anti-CCP. So wala ko naka-search if na by changes, ani. Alright, but this is the criteria established by American College of Rheumatology for the diagnosis of your RA. Alright, so again, at least 4. So minimum of 4, 4 and above. Okay, lasting for greater than equal to 6 weeks. Okay, alright. Ayan. Okay, now we go now to the test that we are going to perform in the lab, the latex agglutination test. So still the same, actually quite same with your ASO pa rin. It's passive agglutination. So the latex particles will serve as your carrier, all right? And they are coated with human gamma globulin. When the latex suspension is mixed with serum containing elevated levels of RF, clear agglutination is seen within 2 minutes. So we have the reagents, latex particles, containing the FC fraction, di ba? Kasi since IgM man ang RF, and it attaches to the FC portion of the IgG. Positive control, serum with RF, and the negative control, serum without RF. Okay, so since it's passive agglutination, unsa man ang imong ginadetect, di ba? It's the antigen. So therefore, yung imuhang RF, which is an autoantibody, serves as the antigen in this test. Okay? All right. And passive man siya. Alright? Ay, mali. Sorry. Nako, Jesus. Sorry, mali. Nako, Mark. Passive, since passive siya, the carrier molecule or your latex particles, it contains the antigen, which is your FC portion of the IgG, which is not normally found, diba? Which is not normally found on the latex. Muto siyang artificial siyang butang. Alright? Sorry, guys. Ayan, medyo sabaw. Diba? Passive agglutination, that's the point. Sorry. Okay, alright. So you're detecting antibodies, which is your FC which is your RF. Okay, all right. So again, in illustration, so we have the rheumatoid factor found in the patient serum, which is again an IgM containing and then you add the reagent, latex particles, coated again with the FC portion of IgG, which is the antigen, diba, kaning IgG. Of course, if rheumatoid factor is present in the patient serum, they then combine and form a visible agglutination. Alright? So, still the same black na slide atong gamiton because the agglutinates are white, so para mas ma-visualize nato. Okay? So, again, there will be a laboratory video for this. Alright? Same with ASO and CRP pa rin. Same procedure. Okay? Alright. Ayan. And that's the end of our rheumatoid arthritis serology. So, quite short lang din naman. Siguro if nag-loom ko ane, it would be much shorter. But sorry naman. So, inari na pag-record kay para daghan ko machika. Alright, anyway. So, again, that's the end of rheumatoid arthritis. Quite straightforward, quite short din. So, I hope na gets lang. Alright, so, yeah. So, don't forget about everything. No? Medyo sabaw ko ron. Medyo lain akong feeling. But anyway, I hope ma-okay ra ko. Alright. So, again, if you have any questions, if na may mga wala na sabtan, again, feel free to chat in our group chat or you chat me. Alright, and I'll respond. Okay, so I hope na gets lang. Alright? Okay, so thank you guys. Thank you dears for watching. I'll see you in our next pre-recorded lecture. Have a great day and keep safe. Alright.